Now, I dug this picture out of the archives, and I hope it doesn't trigger any PTSD in our members who last saw Dr. Gotto dressed like this in the OR just before their surgery. All kidding aside, the Digital Examiner featured Dr. Gotto and his many accomplishments. But did you know that in addition to all those great accomplishments, he was also recognized as our 8th Pathfinder Award recipient in 2022. And since then, he has joined the board of directors at the Prostate Cancer Center. And in 2025, Dr. Gotto received a Cummings School of Medicine Excellence Award for his work in clinical research. Prostate Calgary has its own YouTube channel containing over 180 videos with over 2,000 subscribers and over 442,000 views. But what you may not know is that Dr. Gotto, who speaks at conferences around the world, has 3 videos on the site, and there's been over 4,300 views of his videos. So we are very, very honored to welcome him back to Prostate Calgary. Welcome back, Dr. Gotto.
Well, thank you for the warm introduction. Always a pleasure to join this amazing group and see some old faces and young faces as well. And tonight, I'm really happy to be here. And what our goal was for the evening was to share sort of an update on a new class of drugs that we're using to treat prostate cancer, namely PARP inhibitors, and to sort of explain their role in the treatment of prostate cancer and where they fit in. And that will involve a lot of discussion around genetic testing and when and how we do genetic testing in patients with prostate cancer and the implications that it has. So, I'll go through that in a bit. And as usual, I like to keep these presentations fairly informal. And certainly, if you have questions, feel free to ask at any point and interrupt me. And if I start going into too much detail or something kind of goes over your head and you need clarification, just feel free to let me know. Right. So tonight, as I mentioned, we'll be talking about PARP inhibitors and what they are and what their role is in prostate cancer treatment. We'll talk about their general role in cancer treatment as well. So, as part of the overview, we'll talk about how PARP inhibitors work. We'll talk about the normal role that this PARP complex plays in cancer cells. And we'll talk about how these new drugs might synergize or work together with other cancer therapies or treatments that we're currently using in prostate cancer. We can talk about how different cancers respond to PARP inhibitors and how we select patients in whom they're going to be most effective. And then we'll talk about some safety and potential side effects. And as I mentioned too, the later half of the talk, I'll talk a little bit more about genetic testing in prostate cancer and the relevance of that as it pertains to PARP inhibitors and patient selection. So we'll start with the overview of PARP inhibitors and how they work. So this is something that might be familiar to you. This is basically a DNA double strand here. Remember that DNA is a double-stranded sugar backbone with these nucleic acids that hold the 2 strands together in the middle. And everyone understands the importance of DNA and the relevance it plays. And I won't get into that in too much more detail. But suffice it to say that during cell replication, DNA needs to be transcribed in order for a cell to replicate, but also proteins are produced from DNA and things that allow cells to perform their daily functions. Now, damage can occur to DNA in any cell, and it can occur to one or both of the two strands that are again held together in the middle. When this damage occurs, it can either be repaired or if it's not repairable, the cell might die. And this is happening every day in every patient and every person and every cell in your body. DNA is active and damage is occurring and repairs are taking place constantly. And when these repair mechanisms don't work, different things can happen. Cells can die. Cancers can develop through defective repair mechanisms. So it's vitally important. One of the nurses I work with likes the analogy of this being somewhat akin to healthy hair, healthy DNA, or split ends, where the two strands are not working properly together, and everyone hates split ends, and we need mechanisms to repair them. And with hair, maybe it's more simple. We have these fancy shampoos that you can buy at the drugstore. With cells and DNA, it becomes a lot more complicated. But that's where the PARP enzyme and PARP inhibitors and all the things we're going to talk about next come into play. And this is not a marketing scheme for whatever type of shampoo this is. I don't have any disclosures related to this shampoo. Okay, so what are PARP inhibitors? So PARP stands for poly ADP polymerase. And these PARPs help to repair single-strand DNA damage that allows for cells to survive when this damage occurs, much like, again, repairing split ends in hair. PARP inhibitors prevent PARPs from repairing breaks in the DNA, and that forces cells to rely on other mechanisms to repair their DNA. So when you give a PARP inhibitor to a patient, they can no longer repair these single-stranded damages, and they rely on these other systems to repair their DNA. We'll talk about what that is next. So how do cells normally repair DNA damage? You can see in the diagram here, there's a double-stranded DNA at the top there, and there's a single-stranded break that's termed a SSB, single-stranded break. And there's DNA damage that occurs from whatever process, whether it's injury or radiation or what have you. And that damage occurs, and in a normal cell, the PARP enzyme will bind to that damaged site on the DNA and repair that single-stranded break. If you take away the PARP enzyme using a drug like a PARP inhibitor, the cell is no longer able to repair that damage that's occurred to the single-stranded DNA. And as a result, that single-stranded break can turn into a double-stranded break. And that's a much more serious issue, and that can lead to cell death. But in a normal cell, this activates a repair mechanism called a homologous recombination repair mechanism. An example of something or an enzyme that does homologous recombination repair is the BRCA, which you've probably all heard of, the BRCA protein. That protein, BRCA, is able to repair double-stranded breaks. And so even in these normal cells that have developed single-stranded breaks that cannot be repaired, turn into double-stranded breaks, these HRR systems, including BRCA, can repair that double-stranded break, and the cell might still survive. Yeah, so when you have intact mechanisms like PARP in a cell, you're able to repair single-stranded breaks. And when PARP is not working or is being inhibited by a drug, normally something like BRCA is able to repair that damage without consequence. Now, this is an example of a cancer cell. And this is a specific situation where this cancer cell has a mutation in BRCA. So it's deficient in this HRR repair mechanism. Now, BRCA mutations are common in prostate cancer and in other cancers. We'll talk about that in a little bit. But BRCA mutations are predisposing mutations to the development of prostate cancer, and they're probably seen in somewhere about around 15 to 25% of patients with uh, advanced prostate cancer. So when these cells with BRCA mutations suffer single-stranded breaks and they have intact PARP mechanisms, they're able to repair that single-stranded break and you get cell survival. When you add in a PARP inhibitor, you prevent repair of the single-stranded break, and eventually that single-stranded break in the DNA can convert into a double-stranded break, where there's this complete fracture in the DNA. And in a cell like this one, where there's no HRR mechanism or no BRCA, the cell is not able to repair that, and that leads to cell death. And normally that would sound like a bad thing, but remember that this is a cancer cell, and you don't actually want the cell to survive. So what we're doing here is exploiting the fact that these cancer cells aren't able to repair double-stranded breaks. And so we're trying to predispose them to double-stranded breaks by inhibiting the PARP enzyme and preventing repair of these single-stranded breaks so that more double-stranded breaks are going to occur and the cells can't fix those and they're going to die. And that's how PARP inhibitors work in terms of killing cancer cells. So next we'll get into synergy with other cancer therapies and how these PARP inhibitors might work in combination with other drugs that we're using to treat prostate cancer. So how do PARP inhibitors selectively affect cancer cells? We know that cells that have HRR mutations, like BRCA, are less tolerant of DNA damage because they have no mechanism to repair it when it's a double-stranded break. So any accumulated damage has the potential to kill these tumor cells. Single-stranded breaks occur more frequently and more commonly in rapidly dividing cancer cells. So these cancer cells, because again, they're dividing so quickly, that leads to mistakes and they are subject to these single-stranded breaks that again can turn into double-stranded breaks if they're not repaired by the PARP enzyme. So as those single-stranded breaks accumulate, they eventually will become double-stranded breaks. And these cancer cells that have impaired mechanisms to repair double-stranded breaks, like the HRR mutations or BRCA mutation, for example, PARP inhibitors cannot repair the double-stranded breaks. These cells then release proteins that activate this apoptosis or programmed cell death, and the cell dies. And in this case, that's more likely to happen in a cancer cell, and that's a good thing. Cancers are more likely to develop somatic mutations in HRR repair genes. So these genes like BRCA are more likely to be mutated in cancers. And somatic mutations, we'll talk about in a minute, refer specifically to mutations that occur in a cancer that may or may not be hereditary. So not all somatic mutations are hereditary. They're mutations that might occur in the cancer cell itself.
Dr. Gatto, what's the percentage of hereditary versus non-hereditary in prostate cancer?
Oh, we're going to get into that in a minute, or not a minute, but shortly when we'll talk about genetics and risk in a minute. But if you look specifically, for example, at patients who have these HRR mutations or BRCA mutations, about half of them are hereditary and about half of them are somatic mutations that occurred over the course of the development of the cancer. So about 50-50 there. I don't know if that answers that question, but
Absolutely. Thanks.
not a problem. So yeah, as we've been talking, PARP inhibitors exploit this genomic instability in cancer cells. Again, the cancer cells are replicating quickly. They tend to make mistakes. They're more likely to develop these single-stranded breaks in the DNA, and the PARP inhibitors prevent them from repairing those small errors that they've made. and those lead to bigger errors. And then in those cancer cells where there's a mutation in the HRR pathway, the BRCA pathway, for example, the cancer cell is no longer able to repair itself and will eventually die. Um, Now, these are all mechanisms here that are targeted, or sorry, that are meant to explain how cancer cells can potentially um, outsmart PARP inhibitors and continue to replicate and grow and progress despite the presence of PARP inhibitors. I don't need to list them all here, but basically, there's all kinds of different mechanisms by which these cancer cells can evade cell death, basically by blocking apoptosis or cell death, um, promoting inflammation, evading the immune system, uh, interfering with growth signals, all kinds of different mechanisms here that these cells use to basically outsmart PARP inhibitors. And the idea here with synergistic effects of drug treatments is to block some of these other pathways that these cancer cells are using to evade um, uh, succumbing to PARP inhibitors.
Can you tell us what BRCA is? Isn't that breast cancer?
That's a great question. That's coming up. So BRCA is a gene that's implicated in breast cancer, but also prostate cancer. It was probably initially characterized in breast cancer, which led to its name, BRCA for breast cancer, basically. But since that time, it's been found to be implicated in other cancers, including prostate cancer. And that explains to some degree why patients who have a family history of breast cancer are also at risk of developing prostate cancer or at higher risk of developing prostate cancer because of the potential for that same mutation. Uh, yeah, and so BRCA is basically one of these HRR genes or homologous recombination repair genes that helps to repair those double-stranded breaks and more common in breast cancer, but also, like I mentioned, present in, again, depending on what study you look at, somewhere between 15 and 25% of patients with advanced prostate cancer.
Well, um, picking up on that, it seems that there's a lot of similarities between breast cancer and prostate cancer. Could I don't know if that's true, but if so, could you kind of outline the similarities?
Yeah, absolutely. I think the biggest similarity there is that both types of cancers are hormonally driven, and that's very different than other cancers like lung or pancreatic cancer. But both of these types of cancers are very dependent on different hormonal axes, whether it's testosterone or estrogen driven mechanisms. So that's probably the biggest similarity in the two, where we're using hormonal manipulation to affect progression of the cancer. Obviously, in both types of cancers, we also use chemotherapy and other kind of more broad treatments for cancer. Um, that are more like generally applicable to other types of cancer. But these two types of cancers are examples of hormonally driven cancers where we can use other drugs, like the hormonal therapy that you're more familiar with in prostate cancer. And then, yeah, now we're looking at all these other drug classes, again, like PARP inhibitors, which are also used in breast cancer and other types of cancer, which we'll get into in a minute. But yeah, there's definitely a lot of overlap, but at the same time, all these cancers are also different in many ways. And so treatments that work in one type of cancer won't necessarily work in another and vice versa. And PARP inhibitors, again, work in a subset of patients who have prostate cancer, but not in every patient who has prostate cancer.
Yeah, what I found with the proton beam radiation was the biggest clients were men, and then women with breast cancer, and then kids with brain tumors.
Mhm.
So I had that thing about why is it so similar that breast cancer has these same kind of similarities to prostate?
Yeah, I don't know that I could explain why prostate and breast cancer would specifically be more um, susceptible to proton beam therapy itself. It could be, that obviously breast and prostate cancers are both very common, and maybe it's more of just a numbers thing, and that there's far more men with prostate cancer than any other type of cancer, um, and likewise with women and breast cancer, and that might explain the numbers. But yeah, radiation therapy is certainly very effective in both types of cancer. Okay, yeah, we'll talk a little bit more about PARP inhibitors and their activity in cancer cells. So yeah, what makes PARP inhibitors more effective for prostate cancer? Well, again, we know that PARP inhibitors are selecting for cancer cells and promote cell death through apoptosis or programmed cell death pathways. Some cancer cells evolve mechanisms that avoid these cell death pathways. And in those kind of cases, PARP inhibitors are probably less effective than in other cancers. And so this leads the way for us to look at things like combination therapies that might help to overcome this resistance mechanism by targeting those pathways that the prostate cancer cells are using to avoid death in the setting of a PARP inhibitor. So again, an example of synergy or two different cancer therapies working together. So the fancy term for synergy or two cancer cells, sorry, I keep saying that, two cancer therapies working together is something called synthetic lethality. So basically working together to cause death or cell death in this case. And this is an example of synthetic lethality involving PARP inhibition or PARP inhibitors and AR or androgen receptor inhibition, which is what we commonly do in patients with prostate cancer when we use drugs that are known as AR or androgen receptor pathway inhibitors. Those are drugs like apalutamide, enzalutamide, darolutamide. All those drugs are examples of AR or androgen receptor inhibitors. And so synthetic lethality, an example of that is looking at combining PARP inhibitors with ARPIs or AR inhibitors to see if you can get a synergistic effect by blocking both mechanisms. We know that PARP inhibition, you can see in the blue arrow there, that PARP inhibitors or PARP inhibition leads to inhibition of the androgen receptor, and that androgen receptor inhibition likewise promotes PARP. And so you can see you get this kind of cycle going on where the two therapies could theoretically help each other to work better.
I've got a question about Eligard and darolutamide. They're both hormone, ADT kind of drugs. Like, how does darolutamide work in conjunction with Eligard? Or
That's a great
like,
question. Yeah, so the way that Eligard and other forms of ADT or androgen deprivation therapy work is by suppressing or lowering the testosterone level. And we know that testosterone and other androgens like testosterone drive prostate cancer cells. Again, it's an example of a hormonally driven cancer. And the testosterone and other androgens bind to these androgen receptors on cancer cells and stimulate them to grow. And so, yeah, the first mechanism that we're exploiting there is by shutting down testosterone production. We're taking away that stimulus of the androgen receptor so that testosterone is no longer there stimulating the androgen receptor and driving proliferation or growth of those cancer cells. So that's how ADT works, androgen deprivation therapy, is we're taking away the stimulus. The ARPIs, so androgen receptor pathway inhibitors, um, like darolutamide, apalutamide, enzalutamide, they work by blocking the function of the receptor. Because we know that in some patients, even when you take away testosterone, there are still other androgens, potentially being produced that are able to stimulate that receptor. In some prostate cancer cells, that receptor basically auto-stimulates or stimulates itself without the need for testosterone. And so AR pathway inhibitors like darolutamide are blocking that receptor from becoming activated through different mechanisms and blocking the receptor from moving into the cell and basically stimulating the proliferation of that cell. So yeah, you're kind of blocking. Again, that's another example of synthetic lethality where you're blocking the testosterone on one end, and you're also blocking, the other way that the cell might evade um, the lack of testosterone and continue to replicate.
So like one is a general testosterone, the Eligard, and the darolutamide is more cell specific.
Yeah, yeah, I guess you could say that. So yeah, I mean, the whole time we're trying to act on prostate cancer cells, and so you're either taking away the food for those cells, or you're blocking them from becoming activated, even if they figure out a way to replicate without that food or testosterone. Here we call it like adding an AR pathway inhibitor is, the common term there is intensification. So it's again similar somewhat to this synthetic lethality concept where you're using two treatments together because you're by blocking two different mechanisms, you're more likely to be successful because you're um, targeting all the cells, even if some of them have a mechanism of avoiding uh, that one anti-cancer therapy or avoiding its effects. Basically, yeah, avoiding resistance mechanisms.
It would be interesting to understand, how you select darolutamide versus apalutamide or all of the other mides,
Yeah,
in treating this.
yeah. We have the same dilemma in PARP inhibitors in that there's a whole variety of different PARP inhibitors now, and um, there's never good trials that compare these drugs head to head. They're always compared, against the standard of care, not against themselves. And so, um, when you look at the various trials, they can show similar effects, but it's hard to compare the trials, directly and to say that one's better than the other in terms of how well it works. Um, and uh, and then likewise, comparing things like toxicity or side effects, from these treatments is somewhat challenging because all the trials looking at the different ARPIs or the different PARP inhibitors they're all designed slightly different and they're all measuring slightly different things in different ways. And so, one might show that, one drug seems to have more fatigue or more rashes or things like that. But because it's not a head-to-head trial or like a randomized control trial, um, it's hard to always tease out whether those differences between the trials are real or if they're just a product of how the trials were conducted. But I think certainly like in the case of ARPIs like darolutamide and enzalutamide and apalutamide, they're all, fairly similar molecules with slight differences and they're the same class of drug and they generally work the same way. But um, yeah, different studies
So
suggest.
it's kind of like sorry.
Yeah, different studies will suggest that, one might, bind to the receptor better than the other, or, maybe one leads to more um, substantial decreases in PSA and things like that. But again, because they're not really head-to-head trials, it's again kind of hard to compare them and say that one's necessarily better than the other. Yeah, so yeah, getting into that. So PARP inhibitors have been studied in combination with AR pathway inhibitors in some clinical trials, and it's really those are some of the clinical trials that we've had at the Prostate Cancer Center that we've been working on, and we already have some exciting results that I'll share with you shortly. Um, I mentioned before that ARPIs, again, like darolutamide, that was brought up as an example, are typically used as first-line intensification for cancer. And again, intensification means adding something to the standard treatment. And in this case, the standard treatment is ADT or hormonal therapy, Eligard, which really has been the mainstay of treatment for several decades now in advanced prostate cancer. And now we're looking at ways to intensify that. And ARPIs as intensification has really become a standard of care, or the standard of care for most patients. Whether it's for metastatic disease or biochemical recurrence, even now we're using these drugs as intensification agents, and so they're kind of part of the standard therapy now in most cases. And so, yeah, the next step was to look at combining them with PARP inhibitors um, so that you're basically targeting three different accesses in the cancer cell. And here I say like combination of these two therapies has been shown to improve outcomes for those specifically who have these mutations in BRCA1 and 2. And when I say two therapies, I'm leaving out ADT or Eligard there because again, it's become such a standard treatment that we're really just talking about what's being added on to ADT. So we know, from that whole concept of synthetic lethality that the PARP inhibitors seem to kind of synergize with ARPIs, because on the one hand, ARPIs are inhibiting cell growth, and on the other, the PARP inhibitors are sort of promoting cell death, which again is a good thing in cancer cells. You want these cancer cells to die. ARPIs work by limiting gene expression in prostate cancer. We kind of went over a little bit of how they do that. This is a more complicated diagram that's showing kind of what I was explaining verbally about how ARPIs work differently from ADT or drugs like Eligard. Again, at the top of the picture there, I don't think can you guys see my arrow moving around on the screen or?
Yeah.
Oh, really? Okay. Hopefully that wasn't too annoying. But yeah, up here you can see I mentioned that one of the first things we do is drugs like ADT or Eligard work by getting rid of testosterone so that testosterone is no longer there to enter the cell and bind to these ARs or androgen receptors, and thereby stimulate DNA transcription. So that's how ADT works. ARPIs, again, work slightly differently in that they're sort of directly blocking this AR or androgen receptor. And so even if the androgen receptor is somehow stimulated or bypasses the need for testosterone, the ARPI is there to block the androgen receptor from becoming activated and to block it from translocating into the nucleus of the cell and binding to DNA. And then finally, PARP inhibitors work by blocking the expression of these androgen-related proteins here by binding to the DNA, and that further reduces gene expression. So you can see basically we're targeting three different mechanisms here, but they're all part of the same pathway. And so that's part of synergy or synthetic lethality, working on all these different parts of the same pathway. I mentioned that we've already done several trials looking at combining PARP inhibitors with ARPIs. But are there other examples of synergistic treatment with PARP inhibitors? So There are all kinds of other drug classes that are being looked at in prostate cancer and other cells, or sorry, in other cancers. And in other cancers, these other types of treatments are being looked at in combination, with PARP inhibitors. So drugs like immune checkpoint inhibitors that aren't being used commonly in prostate cancer yet, but are being studied, might be one class of drug that could potentially work in combination or synergy with a PARP inhibitor. These AKT inhibitors are being looked at as well. And then finally, radioligand therapy, which you may be more familiar with, drugs like lutetium that may eventually be studied and looked at in combination with PARP inhibitors and other treatments for prostate cancer.
On the lutetium, this is a fairly new drug for Canadians, and I guess it started in the US for more severe cases of prostate cancer. Could you tell us a little bit more about that lutetium 177?
Yeah, no, absolutely. So yeah, lutetium 177 is an example of what's called a radioligand therapy. So you can see it there. And that's where a radiation emitting ligand is bound to this antibody here. So a monoclonal antibody. And that antibody basically targets this cell surface molecule on prostate cancer cells called PSMA. So in the diagram here that you can see with my pointer, on the surface of this prostate cancer cell, there's this marker or protein called PSMA. It stands for prostate specific membrane antigen. That's what we're looking for when we do these PSMA PET scans, is the presence of these PSMA uh, avid cells. And the way lutetium works is it's this antibody, this little Y-shaped structure here. That's an antibody that basically targets PSMA. And so it finds PSMA and binds to it. And then attached to that antibody is this radioligand or radiation emitting substrate. You can see beta and gamma emission. So it's basically an antibody with radiation attached to it that's delivering radiation directly to the cell. And so that's maybe limiting toxicity from that radiation emission because it's bringing it specifically right to that area where PSMA is found. And it's also making it, getting it closer to the cell and maybe more likely to cause DNA damage and less likely to cause peripheral damage. It's more of a targeted therapy than other forms of radiation. Lutetium is one example. There's other ones out there that are being looked at, actinium and others. And yeah, the one that we have access to currently is lutetium in Alberta, and it's currently being used in patients who have metastatic castration-resistant prostate cancer, so very late-stage prostate cancer, and specifically in patients who've already had chemotherapy and are failing despite chemotherapy. But there are trials that have shown success with giving lutetium in earlier stages of prostate cancer, whether it's metastatic castration-resistant prostate cancer before chemotherapy, or even in the metastatic castration or hormone-sensitive setting, where patients are still responsive to hormonal therapy. Giving lutetium at that stage has been shown to be beneficial in terms of progression-free survival, but those aren't approved uses currently. They're still being looked at and evaluated.
Is it becoming more common in Alberta or in Canada? I guess it's pretty expensive.
Yeah, yeah,
I think
yeah.
we just,
Yeah, well, all these drugs are very expensive. Lutetium,
right,
probably one of the more expensive ones. Typically, patients would get like 6 cycles of treatment, and that costs around $150,000, which is a lot of money.
yeah.
I mean, these other drugs like darolutamide and apalutamide, enzalutamide, I think those are in the range of $3,000 or $4,000 a month. So they're not really cheap either, and you're on them for often many years. I think ADT or Eligard's relatively cheap now, but yeah, it's a lot of money for sure.
Exactly.
But it's worth it.
It is.
Certainly, like things have changed. I mean, I still consider myself pretty early in my career, but maybe not so much now. But I look back when I first started here, it was 15 years ago, and none of this stuff existed. So I mean, it's pretty crazy to see everything that's changed in the last
It's
15 years.
amazing how quickly things have advanced.
Yeah, back then we just had Eligard and chemotherapy, and that was really about it. So
Dr. Gotto, if I may, if I understand that if a genetic analysis shows no mutations, particularly to BRCA1 and 2, that there is little advantage to looking at PARP inhibitors.
So yeah, that's mostly true. So a lot of the studies with PARP inhibitors have looked specifically at patients who have BRCA and then also ATM mutations. Um, it's hard to study some of the other HRR mutations that are out there because they're relatively uncommon, and so there are relatively few patients in the studies that have those other mutations. And so they tend to kind of lump them all together and try to say like BRCA or everything else, um, or BRCA and ATM or everything else. And the everything else category doesn't really seem to have as dramatic of a response to PARP inhibitors. And in the patients who have no HRR mutation, again, there's probably limited benefit. There's some studies that would suggest that because of this synergistic effect with the AR pathway inhibitors, that there might be some benefit to giving PARP inhibitors with ARPIs, even in patients who have um, no HRR mutation or no BRCA or ATM mutation. But again, the effects are modest, and because of that, I think the people paying for these treatments are less likely to fund them in those specific situations, and they're more likely to suggest, as they have in the past, that they be limited to patients who have specifically a BRCA or ATM mutation or whatever group of patients showed the largest benefit in the trial.
Thank you.
Yeah, not a problem. I think I talk in a minute about the different trials that are out. Yeah, I think that's coming up here. So yeah, responses to PARP inhibitors by cancer type. I think I mentioned some of this before, but there are many types of cancer in which PARP inhibitors are used. So we mentioned breast cancer and prostate cancer already, but also ovarian and fallopian tube cancers, pancreatic cancer, other gynecological cancers. We know that, again, PARP inhibitors are most effective for cancers where there's a high rate of HRR or HRD mutations. Again, where those cells are not able to repair these double-stranded DNA breaks. And the most common example, again, is that BRCA1 or 2 mutation. I think I just have some general information on safety in these new class of drugs. So everyone's always concerned about side effects and toxicities and how safe are these drugs. I think generally speaking, they're quite safe. Um, and that's, specifically relative to other treatment options that we have in these later stages of prostate cancer, like chemotherapy. Uh, they still do have, potential for significant toxicities, but a lot of that can be avoided or mitigated by, close close monitoring of patients while they're on treatment. The more common serious things that can happen with PARP inhibitors are this pneumonitis or basically inflammation in the lungs. Um, I haven't seen that myself, but it does occur. And then more commonly, hematologic or blood disorders that can occur, and the most common one is anemia. So low sorry, low hemoglobin counts or thrombocytopenia, low platelet counts. So those kinds of decreases in cell numbers in the blood can lead to consequences. And it's not uncommon to see patients, potentially developing anemia to the point that they need blood transfusions on these drugs. That probably happens in around 10% of patients. And likewise, it can cause decreases in white blood cell counts and maybe susceptibility to infection and other complications. But again, if you monitor closely for these things and intervene soon rather than letting things escalate, you can usually avoid the more serious complications and need for transfusion and that kind of thing. What are some common side effects? We talked about the serious stuff, but more common things, as with most of these anti-cancer treatments. So we have fatigue, loss of appetite, nausea, vomiting, constipation. I mentioned anemia already, and neutropenia and thrombocytopenia. Then to answer some of the questions that already came up, and then also talk more about genetic testing in prostate cancer, and again, how we select patients who are more responsive to these treatments. Thought I'd go through some information just on genetic testing in prostate cancer. Basically, I wanted to highlight the difference in germline and somatic mutations, which are important distinctions to make when you're talking about genetic testing and specifically prostate cancer. Basically, a germline mutation is a hereditary mutation, so one that you're born with. So when we talk about someone passing on a genetic risk to a cancer to a family member, that's a germline mutation, one that's in the DNA in all of your cells in your body. And that's really the one type of mutation that has significant familial risk, meaning that if your father has a BRCA germline mutation and you inherit that mutation, your risk of prostate cancer is significantly higher. A somatic mutation is an acquired mutation, so one that you're not born with. It's not in all your cells, but it develops in the cancer cell. And so that's an acquired mutation, one that you can't pass on to your children or anyone else. And those two types of mutations, germline and somatic, can be the same gene. They could both be BRCA mutations, and they can both have the same implications in how the cells behave and how they respond to PARP inhibitors. But the biggest distinction is in familial risk and genetic counseling and predisposition to other cancers. So yeah, important to do genomic testing in prostate cancer to identify these mutations, and also to be able to select different treatments, look at things like prognosis and outcomes, and then also, again, to screen patients for hereditary cancer syndromes or predisposition to prostate and other cancers. This is a more detailed slide that talks about genetic testing in prostate cancer. These are some guidelines from the CUA, or the Canadian Urological Association. And unfortunately, as with many of these guidelines, they're made with the best case scenario in mind. And unfortunately, in Alberta, we don't have great access to genetic testing, and we don't have great funding for genetic testing in prostate cancer, except in very specific situations where PARP inhibitors might be indicated. So unlike here, where these guidelines are recommending that patients with localized prostate cancer, so no metastatic disease, who have risk factors for genetic predisposition, things like family history of prostate or related cancers, personal history, or specific ancestry like Ashkenazi Jewish history, where there's a very high proportion of patients with BRCA mutations, or in patients who have abnormal histology in their prostate cancer, ductal or intraductal histology, or very high risk disease, high Gleason scores. We know that all these patients are more likely to have genetic abnormalities, and I think it's important to identify those early because they can predict for likelihood of recurrence after treatment, and then eventually how patients are going to respond to some of the treatments that we give them. When you do this testing, and here's a specific example with germline testing, you'll get results back. Either they're negative, they have no mutation identified, no hereditary mutation, or they have a pathogenic or likely pathogenic mutation, like a BRCA mutation, or they have something called a variant of uncertain significance, or VUS, which means that they have a mutation in a gene that may or may not be implicated in prostate or other cancers, and we're not really quite sure what to make of it. And in both those situations, whether they have a pathogenic mutation or a variant of uncertain significance, we also recommend counseling by clinical genetics in Calgary. That's the hereditary genetics program, where the clinicians are able to give us more detailed information about familial risk and what's called cascade testing of family members to be able to quantitate their risk and make appropriate screening recommendations so that they can be followed closely and have cancers found at an early stage and potentially treated and cured.
Well, so with people who have prostate cancer, should we be getting DNA testing now?
That's a great question. If you have advanced prostate cancer,
Right.
yeah, the CUA guidelines would be that you should have genetic testing. Or
Who
certainly,
would you who would you recommend for that type of?
uh, who would I recommend doing the testing? Like which patients or how would you go about doing it, you mean?
Yeah, like what? Who would I approach?
You'd approach your doctor, your urologist or your oncologist.
Dr. Gatto,
Yeah, yes,
what would
sir.
you recommend?
The issue right now is that the genetic testing is not funded or paid for outside of this situation or setting of metastatic castration-resistant prostate cancer, where again a uh, a PARP inhibitor might be indicated. Um, but as per these guidelines and most physician preferences, we'd like to test patients earlier so we can kind of plan ahead, and know what drugs we might use in the future based on their genetic risk now. And certainly, if anyone has a strong family history of prostate cancer or breast cancer, uh, we might be able to refer them to the hereditary cancer genetics program and potentially be able to get access to genetic testing through that route. But right now, the only other way is to pay for it, unless you're in that group of patients.
So, the last I heard was, this DNA testing. Well, you were you came from a dog or something like that, right? So there's a varying qualities of DNA testing. Do you have a recommendation on a quality DNA tester?
Yeah, I mean, there's a few companies that are available, but yeah, again, we can talk about that offline and
All
um,
right.
I'll give you some information on it
Okay.
or some, yeah, sometimes there's other ways to get around the lack of funding, but we'll talk
Yeah,
about
I
it
know.
more. Yeah, so one of the best ways to do genetic testing in prostate cancer is specifically tumor testing. So rather than germline testing, doing specific testing on the tumor where we use um, tissue from the biopsy of the prostate or from a metastatic site, we're able to look for those mutations in the tissue, basically, that's been obtained from a biopsy. And this can be done on fresh biopsy tissue, or it can be done on uh, historic biopsy tissue, archived tissue from 5 or 10 years ago, even from your biopsy. And it's a good way of identifying mutations. The issue is once you identify a mutation in a tumor, you can't tell by looking at it whether it's a somatic mutation that's occurred in the cancer, or it's a germline mutation that the patient was born with. And so you have to do further testing at that point to try to figure out if it's a hereditary or germline mutation. These are some of the risk factors for prostate cancer. And again, things that might suggest a familial predisposition or a hereditary cancer syndrome. So strong family histories of prostate cancer or breast, ovarian, colon, or endometrial cancers. Rarely other cancers like pancreatic cancer, urothelial upper tract cancer, Lynch syndrome, for example, stomach bowel cancer, and then very rarely melanoma, where you can see this sort of overlap with prostate cancer. Yeah, in patients who have a personal history of colon cancer, we think they're predisposed to prostate cancer as well. And then again, in some patients with these other GI cancers, pancreatic, stomach, small bowel, male breast cancer, which is uncommon, but suggests a potential for BRCA germline mutation. And then I mentioned briefly the Ashkenazi Jewish patient population, which is small in Calgary, but this specific group of patients are much, much more likely to carry BRCA mutations than the general population, about 10 times more likely. And so they need to be looked at more closely when they present with these cancers. This is an example of a case. I'm going to skip over some of this. This answers some of the questions I think that came up at one point in the talk, just about risk of cancer in patients who have these mutations. So the cancer risk implications of being a BRCA carrier. So we know that in the red here, the increased relative risk of prostate cancer by age 65 is about 2 to 7-fold. So you're 2 to 7 times more likely to develop prostate cancer by 65 years of age if you have a BRCA mutation. You also have higher risks of other cancers like breast and pancreatic cancers. And then family members will have increased risks of other BRCA related cancers like ovarian and breast cancers. We know that if you have a BRCA mutation, you're more likely to have these things below here: higher Gleason scores at diagnosis, more likely to have lymph node involvement or distant metastases. Yeah, and then more higher likelihood of worse outcomes like metastatic disease or dying of prostate cancer, again, if you have a BRCA mutation. So very important to look for, and once identified, to follow these patients very closely. This was an example of a patient, Tom, 68 years old, who's diagnosed with localized prostate cancer, but has a family history. His father died of prostate cancer. And although his cancer seems relatively low or low intermediate risk with a Gleason score of only 6 and a PSA of 10, he undergoes genetic testing because of his family history and is identified as having a BRCA mutation, a BRCA2 mutation specifically. And despite having a relatively low Gleason score and reasonable PSA of only 10, he undergoes surgery and lymph node dissection, but we don't have his pathology here. But he has worse pathology than he predicted based on his biopsy, and eventually develops a biochemical recurrence of his cancer, which would be less common in a Gleason 6 cancer with PSA of 10 if it were not for the BRCA2 mutation, which again really predisposes patients to worse outcomes and higher recurrence risk. So he has a recurrence and is treated with radiation and hormonal therapy, and initially responds, but then within 3 years develops metastatic disease, castration resistance, rising PSA despite being on ADT. And he's found to have metastases in his lymph nodes and in his spine. And that's a very rapid progression to see in someone who initially presented with a PSA of 10 and a Gleason score of 6. So he's progressed very, very quickly. And this is sort of a classic example of what happens in these BRCA2 patients. And so, yeah, what options do we have? Well, these are some of the clinical trials that we had open in Calgary. We're lucky to have 3 of the 4 here open in Calgary, and now all 4 of these trials have read out and shown improved progression-free survival in patients in Tom's situation who have metastatic castration-resistant prostate cancer progressing on ADT. And in these trials, we were looking at treating patients with PARP inhibitors, like in these cases, olaparib, talazoparib, or niraparib, either alone or in combination with an ARPI, based on the trial and the previous treatments the patient may have received. And so in all 4 cases, we saw significant improvements in progression-free survival when PARP inhibitors were used, again, in a setting of a BRCA mutation. Just to allow some time for questions, I'll maybe end the presentation there, and then happy to answer any questions.
In the MANBAN, the registration process asks the potential PSA candidates if there's any family history, but the family history is restricted to prostate cancer. Why is it not? Why does it not? The question doesn't include breast cancer.
But that's a great question. I should look into that.
Well, I was thinking, since you've joined the board, I put to the people at the Prostate Cancer Center MANBAN program as to why don't we include breast cancer as a possible family history flag.
Yeah, that's a great question. It should be on there. So yeah, I'll look into that. I guarantee you that by the next time I talk to you guys, that'll be changed.
Thank you.
You're welcome.
Yeah, Dr. Gotto, I might not even be on the curve yet. I don't know. I'm looking for information on the process of identification. And I will express that I'm feeling very frustrated in the pace at which this is moving forward. In 2023, my PSA test for my annual went from 3.2 to 3.4. In 24, it jumped to 3.6. 6 months later, it dropped again. Then in 25, in October, I think it was 4. And a digital examination seemed to indicate a bit of a firmness. So that was in October of 25. In the second week of January, I was able to get an MRI taken, which indicated a PIRAS 5. And now scheduling the biopsy is 3 months out.
Yeah,
that's not moving very quickly.
No, that's frustrating for sure, and I can assure you that as urologists, we're all very frustrated by the delays as well. I know that from having recently joined the board, that we're doing a lot of work with EFW, which is our radiology group that's helping or that's doing the biopsies to try to increase the numbers of biopsies we're able to do. And I think there's definitely been some headway in that regard. And I think I wouldn't be surprised if in the next couple of weeks, if you heard about a sooner date because they're increasing the capacity for biopsies, and we're switching over to a new type of targeted biopsy using micro ultrasound instead of this EuroNav system that we've been using previously. And so the biopsies will be faster. We'll be able to do more of them. And then likewise, they've increased their staffing and that kind of thing. So hopefully we can address that. But yeah, there's been long delays. I can assure you that that's not just a Calgary problem. It's happening in Edmonton, and it's much, much worse in in parts of Vancouver. I know talking to some of my friends working there that, patients are waiting, over
Yeah.
6 months for biopsies and things like that. So yeah, it definitely needs to get addressed. And
Yeah, I have looked
unfortunately,
at the geographies and, I could go elsewhere, but then I would be off the system. And that's not a good thing. I was surprised when Dr. I'm sorry, Bahami, the urologist at the clinic. Began with a D. He called me on a Sunday afternoon. In December, or whatever, he said, yeah, we're so busy, I couldn't even see you in the office, so I called you at home.
yeah, these delays aren't because we're not working hard. I'll tell you that.
No, I mean,
You guys are wonderful.
Yeah.
You guys are hard workers.
The
Wow.
theater for doing this, is open 2 days a week. Which also surprised me, I guess it's doing other things other times, but, so your board has this. I go way back in Calgary, we were one of the original donors of Prostate Cancer Center when I knew Doc Seaman quite well, and so now when I'm tapping into it, I'm going, oh gee. By the way, I really appreciated your presentation today. A lot of stuff I've dealt in, but you gave a lot further detail into that I can go further into. So thank you for that. I'm not just crying.
Oh yeah, you're very welcome.
One more question.
Yeah.
The BRCA1, BRCA2, I thought that was possibly a blood test. You didn't necessarily have to have a biopsy. Is that correct?
Yeah, so I actually just skipped over that slide at the end there, but I talked before about germline and somatic mutations. Again, somatic mutations being these mutations that occur in the cancer, and then germline mutations being mutations that you inherit that affect every cell in your body, basically. And so those germline mutations you can test for in the blood because you'll find cells in the blood that have that mutation. Whereas when we're looking at a biopsy of a prostate or prostate cancer metastases, when we find the mutation in those cells, we don't know if it occurred in the prostate cancer itself or whether it's one that the patient was born with and then they developed the prostate cancer on top of that. And so you can't tell from a standard blood test whether someone has a BRCA mutation. But what we are doing now is looking at what's called circulating tumor cells or circulating tumor DNA, where you can identify cancer DNA in the blood and identify these mutations there. So there are ways to do it, but that's, again, not the standard approach right now here.
Yeah, because in 2007, I was tested for the BRCA1, BRCA2 by blood at the Alberta Children's Hospital, and it came back negative in 2007. So I'm just wondering, the test that's old, was it valid in those days? We're talking 19 years ago.
Yeah, I mean, I would imagine that was like a germline test where they would tell you that you don't have a hereditary BRCA mutation, but yeah, if you have prostate cancer, you could still potentially have a BRCA mutation in your cancer. Again, if you look at all the cancers, prostate cancers that have BRCA mutations, about half of them are hereditary and about half are these somatic mutations that occur later in life. But it sounds like it's unlikely that you have one of these hereditary forms.
Yeah, it came back negative, but that was in 2007. Okay. I just wondered how good the testing was in 2007.
Yeah. That I can't really speak to. I'm not sure. I'm sure it's a bit better now anyway.
Well, Dr. Gotto, I'd like to express my gratitude for your work and volunteering your time here at 9 o'clock at night. You've got a young family. Really appreciate. I think if I can speak on behalf of our prostate group, we really appreciate your help and work and assistance.
Oh, you're very welcome. Like I said, it's always a pleasure speaking with you all. And yeah, also it's a good opportunity for me to summarize all the information and review it. Helps me too.
Brad, thank you for organizing this too.
Yeah, good, because we have a whole 4 minutes left, so we don't want to waste it. And that just tells me it was a great presentation once again from Dr. Gotto, because we filled the room up. We took the whole hour, and we had lots of great interaction and questions. So we do so appreciate your time, Dr. Gotto. Um, we appreciate being able to speak to you sort of one-on-one, but it's been a wonderful evening, so thank you.
Oh, my pleasure. Yeah, thank you for having me.